Welcome to Obstetric and Gynecology Forum. I am your host, Dr. Olani, your consultant obstetrician and gynecologist in house. Today, we shall be discussing another important topic in obstetrics, which is known as cervical incompetence. What is cervical incompetence? Cervical incompetence means that the cervix, which is the gateway into the uterus, is not strong enough to hold and sustain pregnancy to term. What do you mean by term? Term is that period when the baby is matured enough to live an independent life without any support. And usually it starts from 3 weeks to your due date. And what is the cervix? The cervix is the gateway to the uterus. It's the entrance and exit from the womb. Now, this part is what we refer to as the cervix. And this cervix is supposed to be closed throughout pregnancy and sustain the weight of the baby inside the womb. Now, what happens in cervical incompetence? In cervical incompetence, due to weakness in the muscle of the uterus or due to damages to this part of the uterus, this part is not strong enough to hold the baby and keep the baby inside the womb. What happens thereafter is that this part will continue to open and the baby will come down, sometimes with the sac. Now, why is this topic very important? It's very important because cervical incompetence is one of the commonest causes of miscarriages, especially miscarriages from around 3 to 7 months of pregnancy. And it's also contributing largely to premature deliveries, that's preterm deliveries. It has a significant contribution to women that deliver their babies preterm. And you know, babies that deliver preterm have a lower chance of survival because they are not matured. And for those that will survive, the economic challenges or the economic impact may be high on both the health care system and the parents. So this condition is very important because whatever we can do to prevent this condition will go a long way in reducing the number of premature births and in reducing the number of deaths in our babies. So cervical incompetence is a situation whereby the cervix, which is the gateway to the uterus, cannot sustain the weight of pregnancy, leading to miscarriages or preterm deliveries. Now, what are the causes of this condition? What will you notice as a woman that will make you to know that you may have this condition? First and foremost, some women that have this condition do not have any sign. They do not have any symptom. And when you take a history and carry out an extensive examination, you may not find any abnormality in them. Those category of women, we refer to them as having idiopathic cervical incompetence. The second category of women are women that have congenital malformations. Congenital malformations are conditions that are inborn. They are inherent in the system of such women. So such conditions may lead to weakness in the muscle of the uterus. And that weakness will also involve this part of the uterus, which is referred to as the cervix. So the cervix in such women is very weak and cannot sustain pregnancy to term. So in such women, conditions that may be associated are conditions like short cervix. The cervix is supposed to be about 3 centimeters at least. And with that 3 centimeters, the length will contribute also to the strength of the cervix. Then some women, the cervix is so short, shorter than that 3 centimeters, making that part very weak. And in some women, because they have some other abnormalities in the womb, that abnormality will cause weakness in the musculature of the womb. So women with short cervix, women with congenital uterine abnormalities in the uterus, and some women that are what we call connective tissue disorders. Connective tissue disorders are generalized disorders in the system, in the tissue of the body of such patients, which will also include the muscles of the uterus, making the muscles so weak. And some of those conditions include conditions like ehlers and systemic lupus erythematosus, which may be beyond the scope of this discussion. Then some women too have what we call exposure to diacylcysteine. This is a particular drug that if a pregnant woman carrying a female baby are exposed to during pregnancy, the baby within the womb will be affected by that drug. And such babies, when they grow up, will have weak muscle in their uterus and in their cervix. The other common cause of this condition is what we call iatrogenic conditions. These are conditions that may be due to medical procedures or medical conditions in the woman that are not inborn. Some of those conditions are conditions that are associated with abortion processes. Women that have recurrent abortion processes, especially what we refer to as induced abortion, abortion that are carried out without medical indications. During the process of trying to dilate or to force the cervix open in order to bring down the baby, this part of the womb may be damaged, and that damage will weaken the integrity of this part of the womb. And like I said, the weakness may be due to the intrinsic muscle weakness or damage. Now, the damage to this part of the womb will make this part not to be strong enough to sustain pregnancies in future. Such women may end up having recurrent pregnancy losses in future. Another important factor are factors that are related to pregnancy. It has been realized that women that have big babies we may end up having prolonged labor or difficult deliveries. Such women may have injuries to the cervix or to that part of the womb during delivery, which may compromise the integrity and strength of this part of the womb. Some of these women too that have large baby or need assistance during the delivery, women that cannot bear down and they have to be assisted with instrument to pull down the baby may also sustain injury. Another women are women that have what we call precipitated labor, very short labor that may occur within less than 3 hours. Such women, because of the speed at which the labor has occurred, may end up tearing this part of the womb. So the tear may now weaken that part of the womb in subsequent pregnancies. Another common complication is what we call cervical laceration. Cervical laceration may occur due to whether the baby was big, instrumental delivery, or women that bear down against undilated cervix. What does it mean? It means that some women will be pushing when it is not time for them to push. In normal labour, the cervix, this place will dilate until the head or the baby can pass through without any trauma. But some women will not wait for that period and they start to push, forcing the baby against this part, and in that event tearing off this part of the womb. Such women may have challenges with the strength and competence of their cervix in subsequent pregnancies. Now, there are some other conditions too that may be used to treat other conditions in the woman, like what we call colonization. Colonization is used to treat some conditions that may lead to cancer in the uterus or to make diagnosis, which involves cutting off some parts of this cervix, or some conditions that may include cutting off some part of this cervix to treat other conditions. Such women too may be predisposed to what we call cervical weakness or incompetence in future. So when you are a woman that has been exposed to some of these conditions during delivery, or you have been exposed to recurrent or repeated dilatation and curative, which we can normally call D&C in this part of the world, you must have it at the back of your mind that you have a higher risk of developing this particular condition. Now, how do such women present? Like I said in the history, these are women that may present to the hospital with history of recurrent miscarriages. Such women may come and tell the healthcare givers that this is the third time I'm having miscarriages. I've had two previous miscarriages, and such miscarriages tend to occur at lower ages. That means the first miscarriage may occur at around 5 months, the second one around 4 months, the third one around 3 months. The age at which the miscarriages are occurring will be coming down. And such miscarriages are usually follow what we call painless cervical dilatation. The babies may come down with little or no pains or bleeding, unlike in typical cases of abortion, where the woman may start having a severe abdominal pain with bleeding. In such cases, the pregnancy may come down without much pain and bleeding. So if a woman has been having that history, she's she's at risk of having what we call cervical incompetence. Some women may come in pregnancy and tell the health caregiver that I feel a kind of fullness or pressure in the lower part of my abdomen or in my vagina. That may be the sign that the cervix is already opening up and the weight of the amniotic fluid and the fetus is already compressing that part of the body. Some of them may come with issue of drainage of fluid per vagina, which we refer to as prom, and some may come with features of labor. So when they present that way to the hospital, what will you be expecting the health workers to do? That will take us to what we call diagnosis. Diagnosis will come from a good history, like the history we have highlighted before. History of recurrent pregnancy losses at lower ages, history of terminations of pregnancy through dilatation and curative, the common D&C, history of difficult deliveries in the past, history of tears and laceration following delivery, history of instrumental delivery, that means assisting your delivery with instruments, history of bleeding after deliveries, history of drainage of fluid, history of premature deliveries in the past. Such histories are taken by your healthcare givers in order to be able to decipher if you actually have risk for this condition. And after taking the history, they will take the history of the present pregnancy. What has occurred? Have you seen fluid? Are you bleeding? Is the fetus still kicking? And so on and so forth. And they may want to carry out some investigations, some examinations first. They want to examine you through the vagina to actually look and check if they are through the vagina. You'll be able to pick out the features of dilatation, because in some women with advanced dilatation, you'll be able to see that actually this cervix is opening up, and sometimes you'll be able to see what we call the amniotic sac, the membrane, the sac in which the baby is bulging, protruding through the cervix. And some women, there may be features of drainage. They may be draining fluid. Some women may have fetal parts like the leg or the hand of the baby inside the vagina. So when such is seen, the diagnosis may be confirmed. And in such cases, if there are features, we want to take samples from the vagina to rule out infection, and you may want to do a scan to look at the age of the baby and to be sure the baby is alive. So they do all those things, and they may want to request, your health worker giver may request for an ultrasound to do those things, and also to confirm that the cervix is dilated. And on the ultrasound, features that they may see will include all of this, any of the following. This is what we call wide deformity. This part that is supposed to be closed is opening up in the upper part. The lower part is still closed. That is what we call wide deformity. In this area, both the upper, virtually the whole length of the cervix is opened and is only closed in this part. We call this V deformity, and this is U deformity, where this part is every part is dilated and even this part is opening up. So during ultrasound, we see a pool of water, which is liquor, in the vagina or the fetal part. So that one may give us a confirmation of the fact that this woman is having cervical incompetence. So, and your health worker will advise you accordingly. Now, having made the diagnosis, I have to say here that diagnosis can also be made before pregnancy. In a woman that's had history of miscarriages, painless loss of pregnancy, you don't need to wait till when you have the second or the third one. You can present to your gynecologist to be examined and to be investigated, because before pregnancy some tests can be carried out to determine the level and competence of the cervix. Such tests include things like what we call traction tests. Some of these tests, what they intend to do is to determine the strength of these parts, and they involve using of certain certain materials to put a test pressure on this part and see if it's going to yield to pressure. And another thing that can be done is what we call HSG, stereosalpingography, that will highlight the inside of the uterus and highlight the inside of the cervix, which may show some opening or defect. There is what we call digital examination tool that may be used to test the strength of this part of the womb. Although this test may not be so reliable, but it will be a guide to the gynecologist to prepare for subsequent pregnancies. Now, and in pregnancy, the diagnosis has been explained that ultrasound, especially what we call transvaginal ultrasound, is very important. The ultrasound that is done through the vagina, unlike the one that is done through the abdomen, it will be able to tell us all of these features that we have explained. It may tell us that this part is short. The normal length is about 3 cm. Anything below 2.5 cm is telling us that this cervix is short and may not be strong enough to withstand the pressure of pregnancy. So the ultrasound may tell us that, may tell us, show us any of the deformity, and through that give us an inkling. Combined with history of recurring miscarriages and make us to know that actually this woman has cervical incompetence. The implication of this is that any woman that is discovered before pregnancy or early in pregnancy will be better managed, and the complications of this condition can be prevented, unlike women that come in advanced case of cervical dilatation in pregnancy. So when you notice any of these conditions, present to your midwife or gynecologist, who will advise you accordingly. Now, how do we manage this condition? Attempts have been made to manage this condition through different ways, because we know that the problem is weakness of this part and the effect of the weight of the baby and the contents of the womb pressing on this place and making it to open. So people have made attempt to say, okay, let's put this woman on bed rest. If you put this woman on bed rest and they are not doing anything that will put pressure on the cervix, maybe we'll be able to prolong the pregnancy and prevent premature deliveries, which has not given very good results. Now, the other thing they have tried is to put what we call pessary. Pessary are synthetic materials that are inserted into the vagina to hold the cervix, to hold the uterus up and prevent this place from opening up. It has also been met with some success, but the success is not what is very reproducible that can be used for everybody. But what we have seen that has revolutionized the care of cervical incompetence is what we call cervical sacrilege. What is cervical sacrilege? Cervical sacrilege is a procedure whereby this part of the cervix that is weak is supported by a band of tissue or rope that is used to tie this, cutting through the substance of the cervix and holding it together to prevent it from opening up in pregnancy. This is the pictorial representation of what a sacrilege looks like. This black part is the rope that is tied across and around the cervix, holding it together, preventing it from being able to open up. And so this sacrilege can be done before pregnancy and during pregnancy, which will be explained later. And this sacrilege can also be done as prophylactic cases or as emergency cases. What do we mean by prophylactic cases? In women that diagnosis have been made of cervical incompetence and there is no significant dilatation of the cervix, after the first 3 months of pregnancy, after which we have ruled out a malformation in the fetus, we have ruled out infection, we have ruled out bleeding and other complications in the woman, this sacrilege is inserted usually after the first 3 months up to 4 months usually, but it can go beyond that. Now this sacrilege is inserted to hold this part before complications set in. That is why we call it prophylactic sacrilege. And for emergency sacrilege, what happens is that a woman that has not been known before to have cervical incompetence is presenting with feature of cervical dilatation, sometimes up to 4 centimeters, without labor, without infection. Emergency sacrilege can be done, although this is more technical, but your obstetricians will pay pay attention to that and prevent complications because they are trained to do that. So they will also put a sacklage, push this back and put a sacklage to sustain the pregnancy. Now, the difference between the two is that the outlook following the prophylactic sacklage, which is not emergency, is better because there is less complication and there is less chance of complication. And the pre-op management is different. In the elective sacklage, it's something that has been planned, investigations have been done, and then you may not need to even suppress contraction in the uterus. You just place the woman on antibiotics. Unlike in emergency sacrilege, where you have to do it when there is already significant dilatation, the patient will be put on bed for about 24 hours, well prepared, and with some maneuver to push back the membrane, because during the procedure, the likelihood of the needle cutting through this membrane and causing drainage of liquor is very high. So, and after an emergency sacral, the woman will stay longer on bed for monitoring. Now, the extent of the procedure is beyond the scope of this discussion, but the sacral, like I said, will be placed and secured. Then what happens after the procedure? After an observation of about 24 hours in the prophylactic and about 48 hours to 96 hours, which is up to 4 days in the emergency sacrilege, and the patient has been found to be stable, when we have ruled out any complication of drainage, of infection, of contractions, of bleeding, the woman will be discharged on drugs that we refer to as tocolytics. These are drugs that prevent uterus from contracting. They also discharge on antibiotics and monitor closely with ultrasound to monitor that this part is not dilating and to be sure that the rope or the sacral is still intact and it has not been displaced from where it was inserted, among other monitoring. Now, for such women, this is one of the conditions whereby a woman may be advised against sexual intercourse in pregnancy. A woman with sacrilege in there may be advised against sexual intercourse, may be advised against carrying heavy objects, may be advised against standing for a long period of time, more than 1.5 hours. Because the more you do all those things, the more pressure is exerted on the sacrilege, and the more the likely that the sacrilege will eventually fail. So such patients are monitored in pregnancy with ultrasound, and if you are able to sustain that to term, the sacrilege is removed and labor will progress accordingly. Now, if any of the highlighted complications of bleeding, of infection, of distress in the baby, of con labor are started, the sacrilege may be removed at any point and the pregnancy managed accordingly. Because failure to remove sacrilege in the presence of infection may lead to other complications. So that is why you may need to remove the sacrilege before the baby is termed. But for those that have abdominal sacrilege, what we call transabdominal sacrilege, usually for women that we have attempted vaginal sacrilege and it has failed, such patient may qualify for what we call transabdominal sacrilege. The difference is that women with transabdominal sacrilege have this need to have the sacrilege inserted either before pregnancy or very early in pregnancy. And for such women, they cannot deliver the baby through the vagina, they have to be over cesarean section. So that is the basic difference between the vaginal approach and the abdominal approach. Abdominal approach means you open up the woman and expose the womb and put the sacrilege. Now, what are the complications that may be associated? Like I said, there may be complication due to the condition itself, due to the fact that the cervix is weak, conditions of prematurity, of drainage of liquor, of infection, of death of the baby, of infection and death in the mother. Those are the complications that may occur. Even bleeding in the mother may occur. But what about the complications of management? Sacrilege is a surgical procedure. Sacrilege insertion itself is a surgical procedure, and we know that every surgical procedure is associated with its own complications. So your doctor may want to counsel you about the likely complications that may occur in the presence of inserting sacrilege. Because the sacrilege is inserted with a needle, the needle may inadvertently cut through the membrane and cause drainage of fluid. It may inadvertently cut through the bladder and cause drainage of urine. It may inadvertently catch between the vaginal wall and the bladder and cause what we call VVF, that is drainage of urine without having control over the flow of urine. It may cause bleeding if it cuts through vessels, and it may cause discharge or infection. So you have to have that your gynecologist or obstetrician will explain to you the likely complications, and the complications will reduce based on the competence of the surgeon and the time at which the procedure is carried out. So then what are the contraindications to sacral? Like explained earlier, a woman in which in whose labour has occurred and is advanced, sacral is contracted. Once a woman is contracting, you can no longer put a sacral. When the baby is malformed or deformed, you cannot put a sacral. Once there is infection within the womb, you cannot put sacral. When there is significant bleeding from the uterus, you cannot put sacrilege. So when there is drainage of fluid, you cannot put sacrilege. And some of the contraindications are the reasons too where you will need to remove the sacrilege eventually. So if any of this also occurs even after the sacrilege, there are also indications for removing the sacrilege. Now, what about the complications? We have said that complications may include infection, may include bleeding, may include drainage of fluid, may include even vaginal fistula, which is persistent leakage of urine through the vagina. So your doctor will attend to that accordingly. Now, in conclusion, we have been able to discuss about cervical incompetence, which is a situation whereby the cervix is not strong enough to sustain pregnancy to term, and which is usually associated with miscarriages and preterm deliveries. And like we have explained, preterm deliveries contribute to a significant cause of death to our babies. So, and we have told us how it can present, and most importantly, we have tried to explain to us how this can be prevented. How do we prevent this condition? Since we know that some drugs in the mother can cause damages to the muscle of the uterus in their unborn babies, it is advised that a pregnant woman should not just take drugs without medical prescription. Number one. The second thing is, we have talked about the damages that are caused by induced abortion, D and C, that is very rampant in our society. That D and C can damage the cervix and later lead to cervical incompetence and recurring miscarriages and preterm deliveries in the woman. So please watch out. Don't expose yourself to induced abortion. When you have miscarriages and you need to be evacuated, go to a standard hospital where the procedure will be done under sterile and competent hands, and by competent hands. Now, we have talked about the role that difficult deliveries play in this particular condition. So that means every pregnant woman should have their pregnancy registered and managed by competent midwives and obstetricians to prevent some of these complications. So complications like tears and lacerations can be prevented. Persistent labor, prolonged labor, all those things can be prevented. And if a woman however has laceration following delivery, the lacerations can be well repaired to prevent these complications in future. And for women that already have these complications, please present to your gynecologist for an evaluation and possible prevention of this condition. Now, in conclusion, our women, the lives of our women are so valuable. The lives of our babies are so valuable. Let us all work together to make labor and pregnancy worthwhile. Thank you very much for listening. If you have questions or comments, please don't hesitate to put them down and get back to us. Till I see you again, thank you and God bless.